Hi, I'm Scott Sullivan. I'm a neuroradiologist here at Greenwich Hospital. And I'm really honored to be able to give the Rick Velaj Memorial Lecture. Worked with Rick in the department here for 9 years. He hired me when I started, and he was a very easy and great person to work with. Working with all that time, you could clearly tell he was, a great husband, attentive father. We have hallway, conversations, but we also have open doors, and you can tell when he's talking to his parents in Italian, and he was really a very attentive family person. He was an outstanding radiologist and was a neuroradiologist like myself, and a very easy person to be with. He had strengths in many fields besides medicine, was often asked for his advice in cooking and travel and clothing and cars, and was super easy to get along with. It was really a great loss for us when he parted. And in thinking of his memory and what would be useful to discuss with this type of forum in sports medicine, I decided that this is a picture of Rick in front of our hallway department here. I decided to do a talk on the workup of back pain, specifically in a young athlete. One of the things that's hard to understand is what radiologists do necessarily all day long. What we think we do most of the time is interpret films. People at the hospital here have ultrasound, CAT scan, MRI, X-rays. We interpret X-rays and send reports to the physicians who request them. But we do a lot more than that, and we really answer questions and other things that don't have to do with the specific interpretation. I think one of Rick's strengths, and one of the reasons I went to do this, is that he was great at giving advice. And we get a lot of questions at times. If I have a patient in my office with blank, and what do we do about this? They don't want to order 3 tests and say you should have ordered the other 4th. They don't want to order tests in the wrong order. And I thought it would be very useful to at least discuss an area of neuro expertise, which Rick and I both have, and focuses on this colloquium in working up specifically the back pain in young athletes. This doesn't cover all back pain in kids. There's a lot of different workups for kids who have other things going on besides athletic workup. Kids with fever, scoliosis, specific neurologic symptoms wouldn't fit this specific criteria, but I think this is a focused area where you can at least learn what would be useful to go forward and use. Back pain in adults, again, it depends on how you describe back pain and how long you need to have it to be under criteria of having significant back pain. But they say that 80% of adults will have an episode of back pain in their life. So the vast majority of adults never don't have an episode of it. In kids, it's not always quite as clear. They've done more and more studies on how often it happens in a kid. It used to be considered extremely rare and very worse in finding for a kid, and the diagnoses were usually considered to be either tumors or some other major issue going on. As more studies come through, it's clear that kids do develop back pain throughout their growth period, and specifically in the teenage years have a much higher incidence of back pain than they do at other times in their life. On top of that, athletes tend to develop more. So they say up to about 20% of kids in their teenage years will have episodes of back pain, and almost twice that will be under kids who are pretty athletic. Now, when I did athletics, I did soccer in the fall and skied and did swimming in the winter and then did track in the spring. And I think it's somewhat different now. I think you've heard a bunch of focuses from the other people that as people tend to focus on a sport earlier and earlier in life, they tend to do more and more repetitive stuff over and over again. So when the 8-year-old out there is going to be the next lefty specialist for the Yankees, and that's what he's going to do, whether it's spring, winter, summer, or fall, you end up developing more issues of complications from that than you would if you were varying your routine from time to time. So young athletes can have back pain as a result of a single acute episode of a problem, or what's probably more common is that they have overuse. They do a single episode over and over again, and they develop pain from that. To work up an acute episode, I think you have to know exactly where they hurt, what their episode was like, and there may be some testing you would do that would be different than others. But to work up a kid who's had an overuse injury, where they, have had a single episode, multiple, stresses on a single area, I think you can streamline it to a pretty efficient workup. What we have available in our department, I put up in those X-rays, bone scan, and CAT scan, and then below that I have MRI. Unfortunately, ultrasound does not have a specific workup. I separated the top three because all those use ionizing radiation. Those use X-rays, whether we either inject them or pass them through the patient to do the tests. But the top three use X-rays, and I'll go over their X-ray exposure as we go through them. The bottom two, MRI and ultrasound, don't use any X-rays. Unfortunately, ultrasound doesn't see through bones, so you can't use ultrasound to work up a kid at this level. I'll go over them sort of one by one, and as we go through. Conventional X-rays or X-rays are where a patient, many may have had them, or stands in front of a detector. We spin X-rays through them, usually from front to back, often from side to side, and get a picture of the area. Depending on how the area stops the X-rays, the picture looks different than it does in other directions. It's really not a good test for kids who have very short episode of back pain that seems to have a fairly benign exam. But a 2-view exam is a pretty good test. The workup for kids with low back pain is actually fairly unrewarding. The majority of cases don't have a result of what it is, and it's considered mechanical back pain. And the specific findings are actually in the minority of patients where you can tell them you have this specific problem going on with you causing your back pain. But of those kids who you have a finding, 2/3 of them you can find on X-rays. So the simple 2-view X-ray actually finds the vast majority of kids who you're going to find a problem with. It finds out what the problem is. In terms of the exposure, 2-view X-rays give kids about 1 millisievert, which is our radiology absorption amount of X-rays. It's about the equivalent of 10 chest X-rays. Now, every day right now, we're getting exposed to X-rays, and over a year, people get exposed to about 30 chest X-rays worth of radiation just for living. Nothing to do with their medical exposure. So 5-view series is probably about a year's worth of X-ray exposure for people, and is probably not necessarily worth the additional look in kids. I think in kids, 2 views really covers the area pretty well, gives them a fairly low exposure, and really will find out most of the disorders what you're going to find. This is a normal looking 2 views of the lumbar spine. We do a view from the front and back, and then view from the side. You have 5 lumbar vertebrae, which are well displayed on both views. And we're looking for malalignment, so we're looking for the front line and back line of the vertebral bodies. We're looking for the size of the vertebral bodies, and you can have compression fractures and other things that replace the vertebral body can result to fracture. We're also looking at the size of the disc spaces. These are the vertebral bodies here, and then in between them are all the disc spaces of the spine. And degenerative disc disease, although considered a disorder of adults, is actually not uncommon in kids as one of the reasons for pain. And finally, the posterior elements here, the superior and inferior facets, where the 2 vertebral bodies transfer weight across the disc space in the anterior column, but also transfer weight in the posterior column through the facets. There's a little small space of bone between those areas called the pars interarticularis, the part between the articular surfaces, that is really a very common place for stress injuries. The posterior elements also have a lot of degree of rotation of the spine and are stressed in that as well. Nuclear medicine bone scan had been probably the mainstay of workup for these kids for a long time. It's a test where we actually inject a material into the patient. The material is radioactive. It goes to wherever it goes to. Specifically for a bone scan, it goes to bones where you have bone turnover. It has some advantages over regular x-rays in that it sees all your bones. It doesn't discriminate. If you have low back pain, that's fine. An x-ray of your low back will see that one area. This has the advantage that you see the entire area. It also is very well tolerated without sedation. Kids, get injected, not so easy to do for most kids, but we don't image them for about 2 hours later. So by that time, it's usually not so bad. The equipment we use is fairly open, and most kids don't need to have any sedation for the procedure. And it's extremely reliable. It's a very good test for most conditions of bone abnormalities. Stress changes in the back as well as elsewhere are usually positive on bone scans, especially very early in their development. One of the disadvantages is that after about 6 weeks or 2 months, it does reduce its sensitivity to the abnormalities. The disadvantage I went over is that we do give an injection for it. Not every kid wants to sign up to get injected. And it's less reliable after 6 weeks. And its exposure in x-rays is more than what we've seen so far. It's about 40 chest x-rays. A normal bone scan will be more than a year's worth of x-ray exposure for people that they get in a year. This is what a bone scan looks like. In a skeletally immature kid, we've gone over a bunch of the areas. The physes has been in most of people's talk. It's an area of weakness in their body, but it's also an area of growth. And when we inject material into a child, it goes to wherever bone turnover is. So anywhere your bones are growing, there's normal places for it to go. The more your bones grow, the longer your bones are, the more intense the activity often is, but all areas of bone growth, the iliac crest and other areas, are all having increased activity than they would at an adult time. In the low back pain, we get specific views of the low back, and again, you can see the 5 lumbar vertebrae. We can get pictures from the front and from the side as well. You can see the ribs, very similar type of picture to what you see from the x-ray, only it doesn't see any structures besides bone. Lastly, the next test is a CT scan. CT scan uses x-ray exposure, but instead of front to back or side to side, we put a tube that sort of spins around the patient, and the detector also spins around the patient. The two of them move in unison, and they make a sort of a 3-dimensional picture of the area. It has the best spatial resolution of any test we have in radiology. So the ability to tell very small detailed things are highest in CAT scan over any test we have. The way it does that is it uses a fairly reasonable amount of x-rays to do it. We, on a regular CAT scan of the lumbar spine, it's about 6 millisieverts, about 2 years worth of radiation exposure for a child. At our department, what we do is we usually do focus exams of CAT scans to specific areas if we can. If someone comes into the emergency room with a trauma and pain, we do a sort of global view. But if there's a specific question, I want to know about L4 and L5, we usually do a focus exam, so we can probably get it down to the 10 to 20 chest range, or about the 5-view lumbar spine exposure rate. And this is what a normal CAT scan looks like. There's a picture, sort of axial picture through a vertebral body. And here's a reconstruction, but a sort of a view that looks similar to our lateral view. We see the 5 lumbar vertebrae. You can see all the disc spaces. So degenerative disc disease and fractures, other things can be seen extremely well on a CAT scan. And finally, MRI is the last test I talked about. MRI does not use any X-ray exposure. It's the only test so far we've gone through that doesn't use any exposure. It basically uses very strong magnets to make these pictures, and without going into the complicated physics, it doesn't use any resolution, and gives very good spatial resolution for what we're doing. The disadvantage of MRI is that not everyone can do it. It's you're lying in a fairly tight tube, and some people are claustrophobic, and some kids don't want to be staying in a tube for a while. The MRI takes a while to get its picture. A CAT scan and X-rays are very quick pictures, but MRI takes a while, and not every kid is really going to have the best results from a MRI. A normal MRI, similar to the CAT scan we show, I showed a picture through the disc space here, sort of a axial view and a sagittal view. You see the 5 lumbar vertebrae, and here you see more details of the soft tissues. There's nucleus pulposus and annulus fibrosus, the things that make up the disc spaces, and these are all normal-looking disc spaces. You can see the spinal cord for the first time, and all the nerve roots that go out every level of the lumbar spine. Those are displayed here centrally, and nerve roots go out these foramina, and the disc is centrally here. You can obviously see how disc bulges and protrusion can be seen very well on an MRI, something you can't see on X-rays and bone scans. And last time before I show a couple of specific pathologies, that I think what people are important to hear is that children are not small adults, right? Children are children. They're immature young adults. They have different structures than adults do. Children have more cartilage than they have bone in many areas, and children are hyperflexible. They have different response to stress that they put on than adults do. This is a normal child's MRI, and this is a normal 40-year adult's MRI. And you see the disc spaces are bigger in comparison to the adults. The vertebral bodies appear a little smaller because the sides of them are mostly cartilage. Those areas are much easier to get injured than bony structures. And it has to do with a lot of the pathology we've been talking about all day and what children are subject to. Anyway, the two most important injuries that you get in for low back pain have to do with repetitive motions, either from hyperextension and with or without rotation, or hyperflexion. Hyperextension disorders are easy to think of ballet and dancing, maybe rowing, but hyperextension sort of goes hand in hand with rotation. Pitchers, cricket players, hockey players, people who do rotations over and over again have specific disorders where they're susceptible to. And people have more flexion disorders, who do their sports where they do more bending and flexing, are subject to more degenerative disc disease, whereas the people in hyperextension are really subjected to spondylotic changes, which is diseases in the posterior elements of the lumbar spine where they could get stress changes. So here's a 12-year-old child who's developed degenerative disc disease. And it's extremely uncommon for kids to have degenerative disc disease. It's in adults. I'm not sure everyone here is being treated presently for back pain, but if we had everyone here volunteer for an MRI today, I can guarantee your MRI will not be normal. And the way I describe it, it's like crow's feet or liver spots. It's whatever just gray hair, whatever you consider normal aging on the outside, we see on the inside. And so they've clearly shown that volunteer studies for MRI, I don't have any back pain, are abnormal. The most common abnormality is this type of abnormality where you get degenerative disc disease. You lose the normal fluid in your disc space, in your nucleus pulposus, and you get weakening of the annulus fibrosus, and you get disc bulges. This patient has more of a disc protrusion. And in an adult, it's garden variety. We see this all the time. It may explain the person's back pain, but it doesn't always. In children, it's extremely rare to see this. Before age 20, it's extremely rare to see degenerative disc disease, especially if there's any changes in the adjacent bone or it has a focal protrusion. And if children have an abnormal MRI with this, I would think it's extremely likely that their cause of back pain is from degenerative disc disease. I'm not so certain if that's true in adults. In more of the hyperextension diseases, we're really looking at spondylolysis. On X-ray, you can see spondylolysis. This is, again, a cone-down view of the lower lumbar spine, vertebral bodies, and disc spaces. There's a normal transition from the bone, from the superior facet to the inferior facet at all levels, except for here, where there's a black line that comes across it, and the child has a fracture of the posterior elements of L5. And it's very well seen on X-rays. The fractures are well seen, but this kid could have had pain 2 months ago or 4 months ago, and his X-ray may have been normal. The stress changes through this area are not well seen on X-ray at all, right? You need to really have a fracture to see it on X-ray. The other tests we have, like a bone scan, can see that this area is hotter than all the other areas around it. This child has, similar to the other child, has abnormality in his posterior elements where he has stress changes or a fracture there, but a bone scan will be positive in both cases. Before he gets a fracture, a bone scan will be positive. That's not true with X-ray. And finally, a CAT scan, or next is CAT scan probably shows best a disorder of fracturing of the same test. You see the facet from the bone above transmitting to the bone below, and then it wants to get the weight bearing to the facet here. Through the stresses of the area, the patient developed a fracture right through there. Very commonly, the fractures are unilateral. Here's an axial view right through the area this way. The fractures are on the left side, and there's some stress changes, but no fracture on the right side. And this is the type of kid who you want to slow down from what they're doing, and hopefully they'll have healing from this fracture because they don't have a situation where they're unstable and have fractures on both sides. And finally, MRI can see the same type of thing. There's a fracture across the post element similar to CT. It's a little more complex for me to show you, but what the MRI has here is that there's some edema or some swelling around the fracture. You don't have to have a fracture, again, to see the swelling. So both MRI and bone scans will be positive before the patient develops a fracture than an X-ray or a CAT scan will. So finally, to summarize my workup, I think the X-rays are fairly useful in children who have, back pain where you have a high degree of suspicion that they're going to have a chronic issue. I think MRI should be the next test. It really is the next best test. It doesn't use any radiation exposure, can see this disease sort of before it becomes apparent on X-rays, right? It can see the swelling inside. It also assesses degenerative disc disease extremely well. And I would only use really a bone scan as the next test if the child was either claustrophobic or too young, where you think, do I want to sedate the child to have an MRI, or do I want to try and get a test where I can find out if he truly has something wrong there? And I would think CT has been really used mostly to see how these areas heal as opposed to primarily working them up. I'll be happy to answer any questions you have, and thank you guys.